I'm so happy to present to you a person I don't need to introduce. Actually, that's Rick Doblin, who is one of the persons responsible for starting this new novel research on psychedelics. He is actually not Amy Emerson. We know that before, but
we sometimes get confused.
sometimes people confuse it. So Amy had to stay in the United States because her
10-year-old daughter went to school and got COVID, and then brought her home, and so Amy has to stay and take care of her.
Yeah.
Looks like a mild case though, but it's a big problem in the U.S. with school starting, even though it was California where most people are vaccinated.
So please take it from here.
Okay. Yeah. So we're having a few issues with the slides, so I'll just start out by saying that I really appreciated the opening talks yesterday, but Garrett, I thought, made some very important points about how we shouldn't go overboard to say that psychedelics are going to save the world by themselves, or that we become Timothy Leary of the 2020s, or something like that. And so I think those are important cautions. But I did want to talk about why I think psychedelics can save the world, just for a moment. But it's obviously not the case that psychedelics by themselves will save the world, and that we need everything working together. Profound political implications. And that for me was reinforced by the Assistant Secretary General of the United Nations, Robert Mueller, in 1983, and he wrote a book called New Genesis, Shaping a Global Spirituality. And what he was talking about is the conflicts between countries are often religious-based, and the fundamentalisms are fighting each other, and so we need a different approach towards spirituality. And it doesn't mean one world religion, it just means we drop into a deeper sense of our connection. So I think it's that sense, and also working through our traumas, historical traumas, epigenetic carriers of this, multi-generational traumas, and that if we can work through that, great. If we can work through that, then we have a chance of treating each other better and addressing the challenges that we face. So that's how I would reframe, Garrett, what you were saying, is that psychedelics for sure not by themselves. Psychedelic therapy is part for the people who have diagnoses, but we need to move beyond that into drug policy reform, drug legalization. We need mass mental health. So that is our kind of theory of change. Okay, so yeah, so I hope that doesn't seem too starry-eyed idealistic and, yeah, thank you. Okay, so with that, though, I've devoted my life to bringing psychedelics back because I think that they can, in proper hands, work together. So we have a dual track strategy. The first track is drug development, and I think that's where you change people's attitudes, because there's been so much enormous propaganda about how terrible drugs are, how terrible marijuana is, how terrible MDMA, one dose, permanent brain damage, major functional consequences, LSD. I grew up being told that if you take it 6 or 7 times, you're certifiably insane. So this talk is coming to you from somebody who is certifiably insane. And to show you how pervasive these things are, the very first date that I had with my wife, and this is back now in 1993, and she wanted to talk to me about a mushroom experience she had in college. But this first moment, she said, I would never have a relationship with anybody like you. And I'm like, well, why is that? She said, you've done so much LSD, your chromosomes must be so screwed up that you would have like a giraffe. And I'm like, well, let me defend my sperm. So that was our beginnings. So you could just see how these pervasive attitudes are spread throughout, and even really intelligent people don't know what to believe. And so the clinical research in medical settings done by doctors, published in peer-reviewed journals, are what changes people's minds through the fact that the media will share those stories. So we have this kind of ability with relatively low amounts of money to educate masses of people by doing the science and also creating more of a consensus among experts about what really is going on, and then that gets reflected in the media, and we've had unusually positive media for the last 20 years. But that's where the education comes from. So that's one track, which is the drug development. The other is the drug policy reform towards mass mental health, because so many of us have sub-threshold anxiety. Just from America, are we going to be taken over by totalitarian Trump again? You know, what's going on all over the world? How, you know, just reading the newspaper about climate change. So that we all have these kind of sub-threshold, if you're paying any attention at all, stresses, and we need mass mental health. So that's the drug policy reform part. And that's our dual strategy. Now, Amy, who, what we like to call her, she is our refugee from Big Pharma. And so she used to work at Novartis, and she's hired a bunch of her fellows from Novartis, her friends and her associates, and then all sorts of other people. And so what we have is our structure, and I'd like to thank Shlomi Raz, actually, who started Elucis Benefit Corp before he dropped the benefit from it, but he told me about Benefit Corps. So what we have is MAPS, the nonprofit, which was started by me in April 1986. And when I started it, I was assuming, because Merck invented MDMA in 1912, and because MDMA had been used therapeutically for years, almost a decade before I even started MAPS, that the therapeutic use was in the public domain, that there's no way to patent it, that it would become generic automatically, and that was fine. But I learned later, actually in 2013, all those years later, that there was this obscure little law that Ronald Reagan had signed into law in 1984, before I even started MAPS, that I didn't know about, that nobody talks about, that pharma doesn't use, which is incentives for developing drugs that are off patent. And those incentives are called data exclusivity. And what that means is that no one can use your data. You have exclusive use of your data for a period of time. In the US, it's 5 years. In Europe, it's going to be 10 years. And then also, you talked about would anybody think about giving these drugs to kids? The FDA is requiring us to give these drugs to kids. If we succeed in adults, 18 or over, we have already signed an agreement with FDA. We must do adolescents with PTSD, 12 to 17-year-olds. And you get extra 6 months of data exclusivity if you do that. So there's incentives for that and requirements. So those are phase 4. We have to do phase 4. If that works, we have to do 7 to 11-year-olds. So that it's not normal, you know, kids who are healthy, but if you also look at cultures that have successfully integrated psychedelics, like the Native American church, like the ayahuasca churches, they don't have age limits. They replace these prohibitions on minors by parental choice. So that I was at a Navajo Native American peyote ceremony, Native American church peyote ceremony, and the Navajo guy brought his 9-year-old son, and he came to this event and ate peyote. Not as much as the rest of us, but he did. So I think that this idea that we're the family values group here, and we're in favor of the family override. And actually in America, 23 states, parents can give alcohol to their kids, even though it's against the law for minors to do it. So there's parental override of the alcohol laws, and I think that's the way it should be with psychedelics. So, in any case, the benefit corporation, which I learned had this property of being able to, in a sense, not exactly monopolize, because other people can get their own data. Other companies can generate their own data. So it's not the same as a patent, but other people are not likely to do that because it'll take them a long time, cost them a lot of money, and they'll just wait for our data exclusivity to expire. But actually what they are doing with the TIE, and maybe we'll hear about this from Srini and others, is they're trying to develop new MDMA-like drugs that they can patent. So that's where the, quote, competition will come from, these new drugs. And so what we can do now is tell our donors, we've raised about $130 million in donations or grants. We've only recently got $12.9 million from the state of Michigan from marijuana taxes for a big marijuana PTSD study. And I'll just say right now that the cannabis for PTSD is palliative, it's not curative, it's not the ideal thing. MDMA, I think, is much better for PTSD, but there's not a lot of people, not everybody is going to want to do the difficult work of psychedelic psychotherapy. And what do we do for them? The other part is that we require everybody to taper off of SSRIs in order to take MDMA, and that's the same with the psilocybin projects. But that's hard for people. But if you could substitute cannabis, you only need to stop cannabis the day before you do MDMA or psilocybin, you'll have full experience. So we're seeing that one day, I think, cannabis can become a medicine for those people that don't want to do the deeper work, or maybe you engage them and then they want to do the deeper work. And I should also say that our first study, 2.2 million from the state of Colorado for this, in cannabis for PTSD, the way we frame it is we demonstrated safety, but the study failed on efficacy. It was terrible quality marijuana from the government. They purposely grow terrible quality so that you exaggerate the risks, and we can talk about whether that's really true, but I think that's true. So we're going to import marijuana for the second study. But the placebo response was so great in our first study that there was no difference between the groups. THC did the best. But in any case, Amy's the head of the Benefit Corp. We now have about 125 people. Around 90 of them are in the Benefit Corp, and we're expanding that quite a bit. And around 30, 35 or so are in the nonprofit. And so what Amy has done is created our own CRO, our own contract research organization in a sense. When I first started doing this back in the early 2000s with our first PTSD study, I got these quotes from CROs, and it was like, this is so expensive. It's ridiculous. And I thought, and Amy had come up to me at a conference, and she said, I'll show you how little I know. She said, I would like to help you monitor your studies. And I was like, oh, what's monitoring? So now I know all too well, as Peter does too. Monitoring is a pain in the butt, you could say, but it's what you need for your data validity for the regulatory agencies to say it. So Amy then completely built up this team. We have this phenomenal team that does this, and so people donate to MAPS. MAPS then gives people tax deductions. And now we have MAPS Deutschland, MAPS, which is just starting up. We have MAPS Israel, MAPS Europe, which is a for-profit, though. We have MAPS Canada with the nonprofit, and we have MAPS US nonprofit. So we try to channel donations, and then we invest in the Benefit Corp. The Benefit Corp will then make these drugs into medicines, and then once they're medicines, based on Elliot's incredible cost-effectiveness studies here will help us persuade the insurance companies that they should cover it, and then the Benefit Corp will sell the drug during this period of data exclusivity. We're trying to figure out now, what price, how we do it, what are aspects of public benefit? Why are we different than now the Elucis Corporation dropped the benefit? How are we different from for-profit companies? And one of the main differences is that we're in favor of drug policy reform. And I think there's a common delusion here, or not delusion, I would say, a mistaken assumption by the for-profit companies that if you can go buy mushrooms legally, or if you can get MDMA for $10, something like that, and if we embed in the culture information about how to help your friends, how to do psychedelic peer support, what is our treatment method, so that we try to develop a psychedelic literate culture that people will try to do healing themselves. And we want that to happen. There are so many people struggling that we want that to happen. But I think what it will do, instead of bleed money away from the businesses, it will develop more people who are, it's destigmatized psychedelic healing. More people will want to go to trained professionals at psychedelic clinics covered by insurance. So I think the move to decriminalize is both good for human rights, it's important for mass mental health, which is our long-term goal, and it's actually good for business. But none of these other companies either believe that or want to get into the controversy of drug policy reform. So that's our dual strategy for the goal of mass mental health. So at the Benefit Corp, though, what we are trying to do and what we've realized is that we've developed this method of MDMA-assisted therapy. We have incredible training programs now for therapists. We've got one that just started online, 100 hours, 522 people are in it just now. We brought in roughly $2 million for the fees for this. We just finished one that was 308 people. Now, the problem with, not the problem, but I'd say the limitation of this is that we believe that there's got to be three components to the training. The first component is you understand the method, you see videotapes of therapy sessions, you end up doing role play, things like that. Then the other part is you get supervised as you work with your first PTSD patient. And then we want to have the third part, which is taking MDMA yourself. And I think that should be true for psilocybin, for other things, that we want the psychiatrists or the psychotherapists who are going to work with this to have experience with the drug. And so we do have a protocol for doing this from the FDA. And we've had about 95 people so far go through this. And it's been tremendous what they say about how much they learned from being the patient themselves and going through it in that way. So that's a problem, though, for us because it's so expensive to do it in a protocol. It's roughly $10,000 it costs us for each person to get MDMA. We just had a senior military psychiatrist, 32 years in the military, and he's at Walter Reed, which is the big military hospital outside of Washington, D.C. He's expert in PTSD, consults with the White House. He just went through this project, took MDMA, and he's like, this is amazing. He said, I will be a much better therapist now. And so as we try to scale this and as we try to do this safely, we need to, I think, have the therapists properly trained as much as possible so that, now, we never want to make it a requirement that people must do MDMA. It's always got to be optional, and you could be a great therapist and have never done MDMA. We're not saying that every therapist who's done MDMA is better than every therapist who's not done MDMA. We're just saying that each individual would be better than they would have been otherwise if they'd not done the drug that they're giving to people. So it's always going to be optional, and we now have consulted with our regulatory lawyers, and the problem is that as you are a pharmaceutical company, as we become, if we get this approval for marketing MDMA for PTSD, you cannot knowingly sell what's called off-label for another thing. Now, doctors and therapists can prescribe off-label because the government doesn't regulate the practice of medicine, but we can't knowingly sell to people who are going to do that, and we can get in big trouble for that. So the question is, how do we make it so people can get MDMA without having to go through protocols so that we can scale this to the thousands and thousands of therapists that we're going to be planning to train? We're talking about training 25,000 therapists. We hope we will partner with Elizabeth and other of her associates that also have their own training programs. So we want to embed this in schools of psychiatry and schools of psychotherapy with other groups. We want to sort of transfer our knowledge so that we can get all these people trained. So how do we do that for 25,000 people? Just think how much that costs at $10,000 a person. So what we're going to do now, and this is that we're going to try to stick it in the label. The label is going to say MDMA, well, this is our plan. We have to negotiate with the FDA and DEA, but the plan is that MDMA-assisted psychotherapy for PTSD, this is what the label says, this is our data, but it requires trained therapists. And the therapist training can include one MDMA session.
so that if we can sneak one sentence, not sneak, but if we can negotiate one sentence into this label, then we can prescribe this or set up clinics where people will come just for that training because it's on label. So that's our big plan, and I think that that's really crucial. 5 minutes. Okay, so we've published our phase 3 data in Nature Medicine, our first phase 3 study. The results were outstanding. In fact, they were so outstanding that they met the criteria for getting approval on the basis of one phase 3 study instead of 2. What that means is our statistical significance was 0.0001, 1 in 10,000 chance that it's random than from our intervention. And 0.05, 1 in 20 is what you have to have for statistical significance. And you have to have 2 phase 3 studies, 0.05 each of them. If you say they're completely independent, that's 1 in 400. So we had 1 in 10,000. We also had no site effects, which means that there weren't some therapists at one site doing so much better than everybody else that's where the data come from. So it's scalable. We had 15 sites, about 75 therapists. We had an effect size. There's 2 different ways to look at it. Placebo-subtracted effect size is the normal way you do it, but in our case, it's not really a placebo. It's 42 hours of therapy. So the therapy is actually very effective.